Good morning, everyone, and welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is The Pursuit is On, Community Benefit. PYA is happy to present today's webinar on this important topic. Before we get started, I'd like to go over a few housekeeping items. As this event is for CPE credit, there are some additional steps we'll take in order to comply with NASBA's requests. In accordance with NASBA, attendees will be provided 5 polling questions throughout today's presentation. Responses are documented electronically. Attendees must respond to these polling questions within the allotted time in order to receive CPE credit for the presentation. If you encounter any issues responding to the polls, please send your answer in the questions pane and we'll document them for your CPE credit. A post-event survey will also be provided for attendees to submit regarding their webinar experience. The polling questions and post-event survey must be submitted for proof of participation today. Credits will only be earned for sessions attended in their entirety. Please remember that this webinar is an hour and a half of CPE credit. You may submit questions during the webinar by typing a message in the questions pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions. We will respond to those questions posed after the webinar via email. We've posted in the handouts pane of the control panel a PDF copy of the slides for your reference, and also you'll receive an email later today with a copy of those slides and a recording of the webinar. With that, I'd like to introduce our presenters today, Debbie Ernsberger, Principal, and Abigail Campbell, Senior Manager here at PYA.
Good morning, everyone. This is Abigail, and I do want to clarify that this is an hour-long session, not an hour and a half, and we'll have 3 polling questions during the hour. So thank you so much for joining. Debbie and I both serve, a lot of tax-exempt clients at PYA, and just want to get right into the content. We will get to the senator's letter that came out in August, and this letter has provided a really good opportunity for us to sort of check in with, what is happening around community benefit and how can we help our clients stay on top of issues related to community benefit. And this presentation today will sort of set the context, basically. How did we get to the letter from the senators that came out in August? Just a brief history on community benefit reporting and Schedule H, again, to contextualize, why are we here today? Why do we need to look at community benefit and be careful about that reporting? So we start, I think generally Senator Grassley does get thrown under the bus a little bit when talking about community benefit. So just, highlighting that Senator Grassley was, really has been a champion for community benefit discussions and regulation going all the way back to 2007 and, just showing a couple clips, 2018 and today, 2023, he is still very prominent in the conversation. And I do want to mention on this timeline that, we've really only been reporting community benefit on Schedule H for, 14 years just about. And in those 14 years, there has not been necessarily a steady focus from the IRS or Congress. It seems to kind of bubble up every few years. So I feel like in the scheme of things, 14 years is not a long time, but still enough time to gather quite a bit of information about the community benefit landscape. So just a brief history, really, just a few key items on community benefit reporting. Again, 2008, we get the Schedule H on the 990, and then mandatory filing begins with tax year 2009. 2012, we see the Affordable Care Act and the 501R and Community Health Needs Assessment come into play, with mandatory compliance beginning after March 2012. So really, only 10 years of this requirement, 10 or 11 years. and with an every 3-year requirement for the community health needs assessment. And what happened with the community health needs assessment legislation was we did see, hospitals starting to work with public health agencies and other organizations to make sure that community benefit reporting was, being done as mandated. And additional requirements, under ACA were financial assistance policies, emergency medical care policies, limitation on charges, and billing and collections, mandate. So this was a really big, robust thing that was implemented in 2012. And now here in 2023, we have 4 senators in a bipartisan effort writing a letter to the IRS and to the Treasury Inspector General for Tax Administration, kind of pushing for answers, requesting a lot of information. We will get to the details of that letter. But how did we get from this initial introduction of Schedule H to these senators writing these letters asking for a lot more information about community benefit reporting? So I think, we kind of have a what was intended versus what actually happened in the scheme of community benefit reporting. And, what the Government Accountability Office, which is the investigative arm of Congress, ended up finding after a few years of Schedule H reporting, they kind of have focused in, and this was looking at 2016 data, there were at least, I believe it was 16 hospitals that did not report any community benefit to their communities. And the IRS wasn't really evaluating community benefit. So, and the IRS wasn't documenting how it was reviewing community benefit. So, we did not, even though the IRS is, collecting this information, it's not taking action on the information the way I think it was anticipated they would. Along, at the same time, we have the American Hospital Association. They have an independent third party they're working with, the Catholic Health Association, and other non-governmental, independent organizations are looking at Schedule H and taking action in a way that goes beyond what the IRS is doing. So these organizations are really using this information, compiling it, providing analysis, and guidance on how to report. And then, the ones who are not meeting expectations become the focus, and a few tax-exempt hospitals become the target of news articles and studies, that are very unfavorable, and sort of are highlighting the issue, bringing attention to all tax-exempt hospitals by being sort of, bad examples, essentially. So we don't have great news around this topic. We also find that, we have inconsistent methodology when community benefit data is analyzed. So, who knows, these news articles and studies, people are measuring community benefit in different ways. And so, it can be interpreted in a variety of ways. And, so then we get kind of this back and forth about community benefit. The Loan Institute, for example, is really issuing a lot of reports that, are saying hospitals aren't providing community benefit to the extent that was expected, but their methodology doesn't include data that is included on Schedule H. The Loan Institute, while Schedule H includes things like shortfall from Medicaid and other government means-tested insurance programs, health professionals training, research, the loan methodology, the loan institute, they're taking all of those items out of community benefit. So tailoring it for their perspective on community benefit. You know, and this Wall Street Journal article is just an example of a headline that, you know, is unfortunately or fortunately drawing attention to this issue. So additionally, you know, so in the meantime, we have the IRS in the background, sort of not sure what they're doing with this data, probably not much, but we see that the states are actually coming in and, you know, wanting to look at this on the state level. And especially in recent years, we have seen a lot of state legislature that's dictating community benefit for their hospitals. And I thought it was interesting in researching this or looking through the different state regulations, the different focus that was coming to light in the various states. So Oregon in 2019, the focus of their legislation was on community benefit floors for tax-exempt hospitals. So you have to meet a certain threshold of community benefit. There are also other states with minimum community benefits, such as Illinois, Nevada, Pennsylvania, Texas, Utah. Some legislation, and this isn't the only focus, but you know, I felt like it was a primary focus. In Colorado, there was a lot of attention in their recent legislation on public dissemination of community benefit reporting. Very prescriptive around how they advertise, you know, public meetings to discuss their community benefit, who should be invited to the meetings. They have to then, you know, these hospitals then have to provide reports on these community benefit meetings, who was in attendance, things like that. So focus on public discussion of community benefit. Illinois in 2021, the focus felt very much on uninsured individuals and financial assistance, and you know, meeting the needs of those individuals, dictating how hospitals were to address those needs. And then Montana in 2023, you know, a big focus on, you know, yeah, the reporting of community benefit and the community health needs assessments. And that's just a small sampling. We have included a few links here to other resources that provide compilations of state community benefit data, so you can look state by state at different state requirements, state reporting. We also have some national analysis, some nice graphics that show the different sources of community benefit as reported on Form 990. And I thought that it was interesting to look at that national analysis and then look at the categories that the Loan Institute, for example, was taking out of community benefit, and you know, just seeing visually what it looks like when those items are removed. And you'll receive these links in the post event handouts that we'll email out. And we are now at our first polling question.
All right, so our first question is, what is your biggest challenge in compiling community benefit data? You'll select one answer: capturing data in real time, communication between departments, reporting format and or software to compile information, all of the above, or we have no challenges in compiling community benefit data. Remember, you must fill out the polling question in order to receive CPE credit. You have about 30 seconds to answer. And while you finish up, I will hand it back over to our presenters.
So Debbie, I wanted to ask you if you wanted to add anything to sort of that historical background and the state landscape.
Thanks, Abigail. Certainly, I think, we've all become a little bit accustomed to not much in the federal world. So seeing a lot of this state focus has certainly increased our attention to community benefit. And, we can see more of that focus as we progress.
Thank you. And yes, so the biggest challenge is seeming to be, the whole thing is sort of a challenge. So understandable, it is a lot of information to compile. So definitely appreciate seeing those responses come in. All right, so now we kind of land, where we are today. And where we are today is we, in August became aware of this letter from the senators asking a lot of questions about community benefit. And, specifically in the first sentence of the letter, growing concern over the growing amount of medical debt and the role that tax-exempt hospitals play in that. The Government Office of Accountability has issued reports on this topic in 2020 and 2023. And there was a report from the office in 2023, actually in April. And so it seems like, with the background of this many-page report from the Government Accountability Office sort of ties into the information that the senators are asking for and about in this more concise letter format. So there were letters to the IRS and the Treasury, and they definitely have different kind of content to them. So the items for the IRS, we found these to be more quantitative, just quantifying what is reported on Schedule H, a lot of requests for lists. So, a list, what are the most commonly reported community benefit activities? How has the IRS updated the Schedule H since September 2020? And again, the GAO report previous to 2023 was in 2020. And in 2020, they did identify some changes that they wanted to see the IRS make to the form. So, and a big, I think, focus has been just on the numbers of I think, there were 30 hospitals with 0 community benefit reported in 2016. And I think that the fact that there were 30 hospitals with 0 community benefit and kind of no action taken by the IRS, the question is just kind of, what is that? What is prompting the IRS to look at these hospitals? Or are they even, what does make the IRS look at a hospital? There were also 108 hospitals in 2016 with less than 1% of community benefit. So, we've got about 138 that are really, not reporting favorably, and nothing's really being done on the IRS side. So then the senators are wanting a list of the nonprofit hospitals that the IRS referred to its audit division. And I will say the IRS, I believe in 2021, did finally add an audit code to kind of trigger audits around community benefit reporting. Who knows? We all know the IRS is very understaffed, and yes, they implemented this code in 2021. We'll have to see if any action is taken, you know, based on the code being triggered. And then, yes, a list of nonprofit hospitals that have lost their tax exemption due to non-compliance with community benefit standard. And, you know, in all this, I think it's important to mention the community benefits quote unquote standard is very nebulous. You know, that you do have to do the community needs assessment. There are certain dictated requirements, but so much of the reporting, you know, there's no really, except on the state level, the IRS isn't saying, you know, the state level's setting community benefit floors and things like that. The IRS doesn't have anything like that. So non-compliance with the community benefit standard is, you know, an unclear goal or unclear idea. All right, let me get this. So yes, another, you know, list of nonprofit hospitals that had their Form 990 rejected for failing to meet requirements, and hospitals that just flat out failed to file a Form 990. And, you know, I will say, I think out of anything that the IRS easily goes after, it is non-filing of a form. So I don't know that we need to spend a lot of time on this, just because I think any tax practitioner knows that it, you know, they seem to be really on top of if a form has not been filed. So, and then the senators are asking, you know, what other challenges does the IRS face and its ability to oversee these hospitals? Now, the items for the Treasury were, you know, again, more substantive, less kind of list making essentially. And their items included how is the, you know, the IRS ensuring that hospitals are providing community benefit, or whether they are, excuse me, or if the IRS is effectively ensuring this. I think we know the answer could be no, but then evaluating the IRS's process for identifying hospitals at risk. And again, these are items for the Treasury to evaluate for the IRS. Assess the effectiveness of the IRS's controls to detect and prevent hospitals' underinvestment in improving community health. So again, these questions are just, what is the IRS doing? Then we kind of get into, you know, is our community benefit standard even effective? Is this working to help us measure community benefit? And again, I think the states have really run with this more than the IRS, and, you know, whether it's an effective standard, it is being used to hold hospitals accountable. And, you know, this is the, you know, although nebulous, these are the metrics and the ideas that we're having to answer to when we do our Schedule H. Evaluate adjustments that the IRS has made to Schedule H instructions, which, you know, haven't been that substantive. So let's keep going. Oh, excuse me. And then, you know, we do get into existing standards for financial assistance policies and medical debt. So, you know, now we're kind of getting into, we looked at the first sentence of the senator's letter, and now we're kind of getting to the meat of that. What are we doing about medical debt and financial assistance? And then, you know, how do we determine if individuals are eligible for financial assistance, and, you know, billing practices with nonprofit hospitals. And again, asking, you know, what are the challenges the IRS faces and its ability to oversee all of this. So these are, you know, just, this is what was in the letter. And I think for us, as you know, at PYA, we just want to make sure that our clients and, you know, hospitals are aware of this information and aren't just, you know, we need to know that this is a conversation that's happening. And we're going to do another polling question, and then Debbie is going to come in with, okay, we have this information. We know, we see the landscape. We know people are talking about it. Well, what can we do about this? So let's move on to our next polling question here.
All right, our next question is, how often do you update your organization's community benefit data? You could select one answer. We continuously update our community benefit data. We compile the data monthly. We compile the data quarterly, or we update this information annually during preparation of Form 990 or other. Remember, you must fill out the polling questions in order to receive CPE credit. You'll have about 30 seconds to answer. While you finish up your polling, we want to thank you for participating, and I'll hand it back over to our presenters.
Thanks, Shannon. All right, let's see here. So overwhelmingly, people are focused on updating this data during the preparation of the Form 990. All right. And I want to say thank you to Abigail. So certainly, let's see if we can advance the slide one. Thank you. Abigail's discussion today has really been focused on building our foundation in terms of all the forces that the tax-exempt hospitals have been feeling for many years. Those forces, probably the tax-exempt hospitals would say, those forces are really leading to a great deal of increased intensity, increased scrutiny. And it almost feels like, as Abigail kind of ends her discussion, we need some type of key music, like we're at this bit of a cliffhanger. I'm going to show my age here. When I was younger, I would watch Dallas, and at the end of that one season, when Who Shot J.R. Ewing, it's like we're at that end of that season. We want to know what's going to be on the next episode of our story. We don't know how it's going to be written. We'd love to have some previews or some insight into that. So here we are with just, let's get ourselves together. Let's think about what we can do in anticipation of some of these forces that we're feeling. So what can tax-exempt hospitals do now? So, I think we all here today recognize the pressures are real. Those pressures are probably not going away anytime soon. And, tax-exempt hospitals, they're feeling a great deal of pressure, some of them from the states. That intensity level from the states may increase. Other states may take notice of what, let's say, Oregon is doing. They may be feeling the pressure for increased tax revenue at all levels. So, we also don't exactly know what's going to happen when the IRS and Treasury respond to the senator's letter. Will this result in increased reporting? Will it result in increased audits? Maybe there's going to be defined community benefit thresholds from, let's say, a federal perspective. That may trickle down to the states. We just really don't know. We all are aware of those third-party watchdog groups. They continue to focus on community benefit. What they're focused on is what's being reported annually on that Form 990, that Schedule H. And as Abigail's already said, we know those third-party watchdog groups, they're using varying methodologies to calculate community benefit and make statements and determinations about tax-exempt hospitals based on their own methodologies. We also know, from a third-party standpoint, we have these stories in the news from those one or two organizations that, made press for some maybe poor decisions or poor actions. But it's something that is impacting all of us because those stories are what many of these senators hear about. So what we need to do right now is to take notice. We know that we need to prepare to weather the storm that may be coming, and that this isn't going away anytime soon. So tax-exempt hospitals have got to be focused on investing the time, investing the resources, and the intention on reporting community benefit. So additionally, this reporting of community benefit, again, we're focused on this Schedule H today. We need to be ensuring that we're reporting this with accuracy. I think we recognize, being in the industry, that Schedule H comes with a lot of administrative burden, which is maybe why that polling question is responded with, we really just do that as part of the preparation of the 990. But there may have been a tendency in the past, perhaps, to underreport community benefit, maybe due to time constraints, maybe due to resource constraints. We know that hospitals functions are, everybody is wearing multiple hats, but it's really time to make sure that we're reporting everything we can that may qualify under Schedule H, and doing so with accuracy. So it's really important for the industry as a whole to take this to heart, because no matter what our argument is in terms of how we qualify for tax exempt status, that community benefit standard, that Schedule H is really where we demonstrate accountability to our communities. And it's important that that be accurate and make sure that we are reporting all that we can on Schedule H, because that's really critical. So let's move to the next slide. And we're going to really start from the basics and build up from there in terms of what we can do now. So if you've not already done so, in light of some of these pressures, it's important that your organization really gather and build a community benefit internal team. And we recognize, these hospitals, they're large. And let's be honest, sometimes the right hand doesn't know what the left hand is doing. So by developing this community benefit team that covers some key internal areas in the hospital, we can really work to try to be transparent and understand where community benefit is being performed in our organization, in the various departments of which that activity is reportable. So without a doubt, the team has to include somebody from accounting and finance. But accounting and finance cannot be the only ones working on this community benefit team. They have to be represented, but it would be important if you have someone in your hospital that has a focus in tax. They might have the unique knowledge that brings with them what the IRS guidelines say, what it is that we're needing to report to the IRS on that Schedule H. Someone for your marketing team that can help you focus to tell the story. Certainly, folks from the development, the outreach team members are going to be important to understand the activities being conducted within the community. If you do have someone that's focused on that community benefit documentation, or the individual maybe that's running point for preparation of the community health needs assessment, they need to be part of the team. Someone representing the research department if we have that. And if you have someone in internal audit, that would be a really important member who could assist, from the standpoint of developing a process, and also from the standpoint of how we document and provide for a trail of the reported numbers on Schedule H. And if you have an education director, that person would be a wonderful asset to the team, as well as someone in volunteer services. So let's advance to the next slide. So we're at the point, we have the members on our community benefit team identified, and we really need to set a cadence for the meetings, set a timeline for the key items. And this is going to be important, if you're a calendar year filer, if you're a fiscal year, no matter where you are in that timeline, this needs to be a priority. And the team that's been identified, they need to understand the importance of this team and really make this a commitment. So we need to establish focus meetings that are initially, we need to be, reviewing, educating, and understanding each line of Schedule H. What are we reporting? and how each line on Schedule H plays into that overall community benefit percentage. So what does each line mean? What goes into each line? And we need to look at that based on reasonable guidance. So that guidance can be, let's get familiar with what the IRS says is the definition of each one of those lines. Without a doubt, let's look at Catholic Health Association guidelines. They've been instrumental since the beginning of publishing documentation and being the leader in terms of question and answers on community benefit. What are other similar organizations considering as community benefit, and what are they reporting? So, when I think about community benefit, I think, unfortunately or fortunately, depending on how you look at it, there's no real common definitions of community benefit that the IRS uses. It's not a bright line test. It's not black and white guidance. And so at times it's really left up to the organization to take that guidance and interpret it. That provides a great deal of flexibility to your team. Some people operate well in flexibility, some people do not. But we have to use those resources available to make that determination of community benefit, and then really work to document the determination of why, or perhaps why not, we're counting something as community benefit. Again, just providing this trail internally as we develop this process and focus on community benefit. It's important that that internal team, once you've gotten familiar with each line of Schedule H, let's look at our Schedule H from a historic perspective. What have we considered? What have we reported on each line previously? What did we do previously to gather and report for that current year? And really be ready to challenge ourselves in terms of how it's always been done in the past. Does that still make sense? Or are we underreporting things? So the key goal for the community benefit team is going to be reviewing and considering what should be reported, really with a fresh set of eyes, and a fresh set of eyes coming out of all of these pressure points that we've been feeling, with the knowledge that, this bottom line percentage matters. The community benefit percentage that we reflect on Schedule H, page 1, is important. And it's not just checking the box for purposes of, essentially completing a task. So let's move on to the next page. So, once we familiarize the team with Schedule H and the various lines and the past process for gathering information, we may need to establish a new and improved process for gathering information and the actual expenses that go into each line. This is really a point where, again, the internal audit team can help in terms of that process for gathering reportable items, and documenting those reportable items in case any questions might arise. And so what would be important at this time is really then going through almost a line-by-line approach of Schedule H. So analyzing each line and how are we going to gather the information to support each line. So for instance, if you're thinking about Schedule H and that going into that community benefit percentage, the first line is always financial assistance at cost, or what we refer to as, of course, charity care. So remember, when we're talking about charity care, financial assistance at cost, we're not talking about bad debt. We're not talking about uncollectible charges that we've recorded as revenue, but truly charity care. So this is why the classification is so important on the front end. So the team has to stand back as they're gathering the data for those numbers and say, do we have the process in place internally to make sure we're capturing all that is charity care? And as we progress, we're going to go into some other items about charity care that we could be doing to make sure we're capturing as much as possible. But, again, that team's got to look at that number and ask those questions. As you continue to kind of think through Schedule H, the next line would be Medicaid. That's really a fairly straightforward calculation. And then the costs of other means tested government programs. We're talking about government-sponsored health programs where that eligibility is based on that recipient's income or assets. So like a children's health insurance program. We're not talking about programs that include VA or Indian Health Services, but those means-tested public programs. And again, do we have that process internally in place to make sure that we are capturing the costs associated with that? So I just briefly talk about those 3 lines because when you look at any analysis, that's usually the most significant portion of community benefit expense for any reporting hospital. So you got to ask yourself, for those 3 lines only, how are we gathering the numbers, and do they make sense? Do they make, when you look at that charity care number, let's say, does it make sense in light of our patient base? So for example, if that financial assistance cost number is really low, what's going on? You got to ask, what's going on? Are we missing something on the front end? Or is that really what our patient base looks like? What might need to change to impact that charity care number? And then also, as you calculate these numbers, how do they compare to what the American Hospital Association publishes annually? That's always a little bit, looking historically, but it certainly gives you the ability to see how you compare to other tax-exempt hospitals, and you can extrapolate that data in terms of what might look closer to your particular size of a hospital. And then certainly this group's got to look at all these other reportable programs, in particular community health improvement services, community benefit operations. That sometimes is certainly a number where we can obtain a lot of community benefit. So those are activities that are really focused on education, outreach services, prevention services. Those are things that we go out in the community to perform that don't generally generate a patient bill. So many of these items are going to be considered free, and if they're not, we charge really just a nominal amount. But really looking at your activities, that's why it would be so important to have someone in outreach possibly on your internal community benefit team, so they can make sure you're capturing all the items here. Because I know of so many hospitals that are out in the community doing these type of things, but are we capturing all those expenses appropriately and reporting them when we go to Schedule H? And certainly we do want to highlight subsidized health losses or subsidized health services, bring some attention to this area. We know and acknowledge that that area takes significant work. It's probably the most underreported area of community benefit. So when we're talking about subsidized health services, we're really focused on clinical services or programs that a hospital provides, but they lose money. And we do it because the community needs them. So, what's important here when we're analyzing these particular areas, we can't double count certain areas. So it means we've got to look at these programs to see if do we still have a loss once we remove bad debt, financial assistance, Medicaid, other means tested government programs, because we can't double count. We've already picked that up above on Schedule H. So are we still providing these services at losses and that meet this definition and picking them up to include? For qualifying programs for these subsidized health services, we're talking about sometimes inpatient and outpatient services. There could be specialized ICU services, maybe mental health programs, maybe some physician clinics that are operating in certain rural or remote areas. This is really an area that has to be considered annually. These areas could potentially change. And, quite frankly, we saw these areas change during the pandemic as, there was a shift in services. So that's why this area, we recognize it takes a great deal of work, probably the most underreported, but definitely needs to be considered by this internal community benefit team. All right, if you'll advance the slide, please. Additionally, that team, we need to think about on Schedule H to make sure that we're accounting actual expenses incurred. It's certainly easiest to consider actual expenses because we're, going to match those up with our financial statements. They're going to be in accordance with GAAP. You could almost think through that those expenses are reported as expenses on the 990, but we're not counting opportunity costs. Community benefits, they are valued based on the actual expenses incurred. The team needs to also be looking at cost accounting methods utilized, make sure that they're accurate. So, when you think about it, in essence, community benefit reporting is really based in cost accounting. So we need to look at whatever method is most accurate to rely upon. So that could be ratio of patient care costs to charges, some, other specific cost accounting system, or maybe the Medicare Medicaid cost report. And then also we have to consider indirect costs as part of community benefit, not just direct costs. So we need to document that allocation method. Once we've established a methodology, work to, have that to be fairly consistent year over year. But we find many times community benefit costs may be underreported as the direct costs that are fairly attributable to the activity just have not been included. And quite frankly, the Schedule H instructions, this is something they specifically note to make sure we're considering both direct and indirect costs when calculating that community benefit percentage. Advance to the next slide. So let's also, when we're thinking about community benefit, we have to also consider and review other policies in place at the hospital. So what are we talking about? We're talking about the policies that determine eligibility for free care, that determine eligibility for discounted care, your charity care policies. So, in fact, when you think about it, these items are included as disclosure items right on Schedule H, top of the page 1. So what are the percentages that your organization uses in terms of federal poverty guidelines as a factor in making this determination? And have they been reviewed lately? So we say that because, maybe there have been payer mix shifts. Maybe you're a state that's been impacted by Medicaid expansion. And if so, has your free care percentage been reconsidered? So for example, if you have set your policy, your free care at 150% of federal poverty levels, but let's say Medicaid expansion is set at 140%, 145%, then your charity care may be fairly minimal. And is this what you intended it to be? On the reverse side, maybe you are located in an area of their community, perhaps based on your zip code, that's a more affluent area. And as a result, maybe your free care percentage should be much higher, maybe along 300 or 350%. So these are all questions to consider to make sure you're providing charity care where available. You have not had some unintended consequence impact your charity care. And if you have low charity care, knowing all these outside pressures, you have to think about that low charity care number, reporting it, and what it may or may not say about your organization. So let's advance to the next slide. Additionally, let's take a look and review our financial assistance policies for any updates that may be needed. Our focus here should be that we are certainly appropriately categorizing charity care on the front end rather than later when it may be considered bad debts, but also looking at opportunities that we might have that maybe allow for some presumptive basis decisions, that maybe we don't have a financial assistance application, but we can look at things on some publicly available information, perhaps information based on data specific to zip codes that may assist with that upfront determination. So that's important because if there are concessions we make or things that we have again, publicly available information, that we could make those presumptive basis decisions to categorize that as financial assistance at cost up front. So let's move to the next page. I think this might be a polling question.
All right, this is our third polling question. What primary resource does your organization use to guide community benefit reporting? You've got 4 options here. Please select one. Our accounting firm provides guidance, IRS instructions for Schedule H, resources from CHA and or AHA, or guidance provided by state governing bodies and associations. Remember, you must fill out this polling question in order to receive CPE credit. You'll have about 30 seconds left to answer. This is our final polling question. Thank you for participating in this poll. I will hand it back over to our presenters.
All right, so it looks like the majority of folks are using Schedule H, but certainly almost coming really closely a lot of other guidance as well, including accounting firm as well as the Catholic Hospital Association. All right. So let's move to the next slide. Yeah, thank you. Again, some things that organizations can consider doing now. One of the things that would be important, as again, we're focused on community benefit, is really taking a close look at the current legal organizational structure. I say that because it's always a good idea to look at the structure, and knowing this intense pressure on community benefit, are there activities located, let's say, in a for-profit affiliated organization that maybe it makes more sense that they're located or housed in that tax-exempt entity? Perhaps the nature of those activities is more in line with community benefit, or potentially, let's say, a subsidized health service. So, it's important to take a look, again, with a fresh set of eyes at the current structure and really look at the activities being conducted. And in light of this focus on community benefit, should anything be reconsidered? Also, considering restrictive contributions. Now, there may be opportunities, given that we have to meet the very specific guidelines of the IRS on Schedule H in terms of restricted requirements on contributions, but are there opportunities when there are payments made to an affiliated group member that may really be in the nature of a contribution or a subsidy, that we restrict them in writing, and as such be able to reflect them on Schedule H of the organization providing that restrictive contribution as part of our community benefit percentage. Items to consider. And then certainly with the next slide, we really can't take our eye off continuous internal education as it relates to our tax-exempt mission and community benefit. This is really part, I think, of a focus on establishing a community benefit culture. So this is going to include key departments and team members, probably those same key departments and team members that are part of the community benefit internal team. But, as we've discussed several times here, a few small bad actions in terms of some collection efforts have resulted in the tax-exempt hospital industry as a whole taking a bit of a hit. So those bad 1 or 2 stories have been applied to everyone. So let's make sure your organization is not found in the middle of one of those stories. So, educating those key departments and team members, and in particular, making sure we're including that education with the billing and collection personnel, and making sure they understand what it means to be considered tax exempt. So, establishing that focus on the community benefit culture which really would come from that community benefit team, will really ensure the story of your tax-exempt hospital conveys the true benefit to the community that it serves. And then on the next slide, you know, we talk about telling your story. We talked about why that would be important as well, to have someone from the marketing team on your community benefit team. But really, finally, don't let Schedule H be the final road of communicating and defining your community benefit for your organization. You know, Schedule H is very specific as to what counts as community benefit, but there are numerous community benefit items that are funded by tax-exempt hospitals that don't perhaps meet the definitions of reporting on Schedule H, but it's really up to you as an organization to make sure you're communicating to your community that true care and benefit. So when you think about it, a hospital in a community, they provide an enormous impact to the local community in terms of employment and hiring, purchasing items from other local businesses, and even the capital investments that they make in the community. These are all things that are provided, but that are not necessarily reflected in the percentage on Schedule H. But it's really important to let your marketing team focus on this and make sure that they are sharing this information, telling your story, and then publicizing it widely. All right, Shannon.
Thank you so much, Debbie and Abigail, for all this great information. Now, please remember to stay on the line once this webinar disconnects to complete our short survey for CPE credit. Your CPE certificates will be emailed to you in 3 to 4 weeks. Later today, you'll receive an email with their contact information and a recording of this webinar. Also, the slides and recordings for every episode of PYA's Healthcare Regulatory Roundup series are available on the Insights page of PYA's website. That's pyapc.com. While you're there, go ahead and register for other PYA webinars and learn more about the full range of services offered by PYA. Again, please remember to stay on the line once this webinar disconnects to complete a short survey and post any questions you may have. On behalf of PYA, thank you so much for joining us and have a great rest of your day.